This podcast is sponsored by ZEISS Professional Education.
Hey everybody, welcome to a special episode of GT the Podcast. My name is Paul Singh. I'm an anterior segment glaucoma surgeon out in the great state of Wisconsin. I'm a true cheesehead, Packer fan, gotta love it. And I'm here with some New Yorkers, man. We got some New Yorkers on the line today with us. Good friends of mine, awesome educators, surgeons, just cool people. And that's Sarah Van Tassel out in Cornell, out in New York. What's up, Sarah?
Hi, Paul. Great to be here. Thanks for having me.
Oh, this is awesome. Looking forward to a fun discussion. And of course, the one and only Dr. Joe Panarelli out at NYU Langone. What's up, buddy?
What's up, my man? Probably the only person who might be able to talk as fast as you.
I don't know. Someone actually asked me that. Who talks faster, me or you? And I wasn't sure, man. It was a tough one. She pulled up a recording of you at one of these lecture halls. And I was like, I think he's faster, man. I think you got me.
We'll see tonight.
We'll see tonight. It's gonna be a lot of fun, guys. But thank you everybody for joining us. Now, honestly, today, I like to talk about MIGS and surgery. I know you're a big fan of subcons MIGS, and of course, Sarah, a lot of MIGS stuff we talk about. But tonight, I want to get away from kind of the surgical part and talk about kind of the real day-to-day running of the practice, right? I mean, as much as I love surgery, I love being in the OR, a lot of my time is spent in clinic, kind of managing, following patients. And I think, when we think about all the forces and all the stresses that we go through, we have all these patients coming our way now. We have really, I think, kind of not enough surgeons, not enough ophthalmologists, and even optometrists kind of taking care of these large number of patients coming our way. And also we have now a lot more patients living longer, and we're diagnosing a lot earlier. So my question to you guys is, how do we maximize flow efficiency and make those decisions? And so to start with, I want to get your thoughts on when you see a new patient. I know it depends on how severe they are, or if they're a new patient with history of tests or not. But when you see a new patient, what's your flow like? Anyone want to comment on what test do you order? First patient comes in, new glaucoma eval. Sarah, what do you order in your practice? What do you want to have at your fingertips in that first exam?
Yeah, I think the four things that probably matter most to me for that visit are pachymetry, gonioscopy, a field, and an OCT RNFL and macula or GCL. There are other things I would potentially like to have, a photo, ideally the pressure, although I would actually grant you that I would rather have those four things first above the pressure. But that's my wish list: gonioscopy, pachymetry, OCT, RNFL, and GCL, and a field.
So I want to ask you some more questions on that. But Joe, what about you? What are the key tests you want that first visit, the first time you see a patient, no matter what they come in?
It's a great question, and I agree totally with Sarah's answer. I will say that the biggest issue we all have is time, right? I mean, I wish we could all say that our clinics run so efficiently that we can get everything that we want. But for me, I'm pretty much making out of there pretty much only with an OCT most of the time. And that has to just do with the fact that a lot of what I try to do is work beforehand. So I try to get a lot of the old records, a lot of the previous visual fields, so that I can sort of streamline the visit. But yes, ideally I would get probably everything, Sarah. I do get a pachymetry. We do gonioscopy and typically an OCT. I've abandoned the fields, man. I can't do it.
I know, man. I tell you, man. Well, it's a hard thing because to diagnose glaucoma based upon kind of the guidelines, right? You have to use visual fields to diagnose severity, mild, moderate, severe. And a lot of times when we do surgeries or procedures, we have to diagnose the severity, and you can't do that without fields, which is such a pain in the butt because sometimes you need that first to make that decision. But in general, Sarah, I want to go back to what you said about all these great tests: OCT, visual fields. You want gonioscopy and pachymetry. I use hysteresis a lot. I'm a big fan of corneal hysteresis as well, which gives you an IOP measurement too if you don't have time for applanation. But I think I want to ask you your thoughts. How does the flow work though? So these are all the tests you do. Do you want them all at one time before you see the patient? Do you see the patient first and then get some testing? How does that work in your clinic?
In my practice, everyone gets the field first. And if they're truly new to the practice, then they typically get an autorefractor manifest, so to speak, so that can be properly plugged into the HFA. And so then after that is when they would see a technician for workup. I'd gonio them at that time. Typically we get them dilated if appropriate, and we'd get the posterior imaging, and then I'd see them for discussion of all the data and my recommendations.
Okay, so fields are first. Joe, for you, I mean, did you get a lot of stuff done before you see the patient? Do you see the patient first? And when do you dilate? You made a good point, Sarah. Do you guys dilate every initial count, or do you just have them come back for DFE?
I dilate them all, mainly because I want to see that nerve. I want a good view of the nerve. As much as I do love all the testing that we're going to talk about tonight, to me, it's something about your gut feel when you look at that optic nerve, in terms of, your worry for that patient. I would say, Paul, a little bit depends on sort of what your practice and how it's built. My practice has morphed a little bit over time. So probably earlier in my career, I saw more glaucoma suspects, more mild cases. And for those patients, really, I could get by with an OCT. I now have, I think, a patient population that is more steered towards, those with more advanced disease. And again, that's why I try to get their old visual fields, and I can actually trend and see how they've been doing, because one new visual field with me often isn't going to help me make a surgical decision. So I like to really put the whole picture together and then actually just listen to the patient and see how they're doing in terms of, their ability to function. So I think it really does depend upon how your practice is set up and what type of patient population you take care of. But for me personally, if they're pseudophakic, I just dilate them all. I take a look at that nerve. I get all their old testing if I can. And I do like to do gonioscopy for anybody who's phakic.
Okay, so do you do gonio before dilating for every patient?
I do. If it's phakic, I go in, I tell my techs, come grab me. Let me go in the room, quickly do the gonioscopy. I tell the patient, I will be back. I promise. Just let me out of the room. And then I come back and we'll finish everything up later.
No, that's a really good point. In terms of kind of workflow from a field perspective, so I do think I like to have a field at first visit. And you're right, if they've had a history of, they've been referred by another ophthalmologist or optometrist and they've had fields already, it's great to have that history as well, because you can make better decisions knowing on the progression, et cetera. And I'm not as worried then getting my field, but especially if it's a new patient, never had fields before, I definitely like to have a field first. But the question is kind of who does the field? Do you have a specific testing tech in your departments, or do you have kind of all technicians do every testing, or how does that work? Testing techs or full techs, are they all the same? Anyone want to comment on that?
In my practice, we have dedicated visual field technicians, though all of our technicians can flex into that role on an as needed basis. But, barring call outs or absences, we have at least one, if not two people who are dedicated to sort of the flow and the execution of the visual fields on any given day.
Yeah, almost exactly the same. At my prior hospital, we actually had our tech who took the patient, really stayed with that patient throughout the entire journey and did all the testing themselves. What amazes me, and I don't know how the two of you feel, is, I don't know, only in medicine sometimes can you start the day and have no idea how much testing is going to get done. And yet somehow you're going to figure it all out. I feel like got to use like the Disney model. They totally know how to like batch people through a park and really maximize efficiency. I feel like we don't quite do that super well. We can go from a day where we're doing like 30 fields to a day we're doing like 15 fields. And I don't know. I mean, in terms of workflow, how do you guys handle that? How do you do it? And Paul, do you see the standard? Are you fast? Are you faster? Do you think there's any difference? And Sarah as well. I want to learn from you two as well here, if I'm doing it right or wrong.
Sarah, go ahead. Since I've been moderating, go ahead.
I'm pretty committed to C to fast. 24-2 is my standard go-to, but we let the technicians have some ownership there. So we have a algorithm. If the vision is 20/80 or less, they typically change to STEM 5. There's some nuance to that, but usually that ends up being a 10-2, but 10-2, but you can do a 24-2 with the bigger stimulus also.
Yeah, I like C to faster, but I like the 24-2C. I like having those extra points. I've picked up a few patients' paracentral changes that I didn't really think I would pick up on a 24-2. And then when I see that, I'll order a 10-2 as well. So I like as a screening, a really good 24-2C. It's actually faster than a standard. And it does give you that some of the central points to kind of help you understand some of those patients. I picked up one today, actually, a kind of a normal tension glaucoma patient where it was just kind of paracentral changes off the optic nerve. And that really kind of helped me a lot. So that's kind of my go-to. But, I do have dedicated testing technicians. And what I found from a flow perspective as well is it's really helpful to have, if you're backed up with your visual field machine or backed up with OCT, having technicians just understand the flow. I don't know, do you guys have a flow coordinator? Because for me, it's important to say, look, you know what, let's work up reversed. We have a certain dedicated way of working up patients, vision, OCT, this, that, visual fields. But sometimes if things are blocked, there's let's say a backup in the fields, work them up in reverse order. Do you guys have technicians that are able to kind of think on the fly, like, you know what, let's work them up back?
I have one person who's been with me for probably 12 years now, Sammy. If Sammy doesn't come to work, I don't come to work. She runs the show. She could actually practice glaucoma as good as we could. No, but you're totally right, Paul. There has to be somebody who can troubleshoot. There's always going to be bottlenecks. There's always going to be, areas where you have holdups, and sometimes it's the patient who just doesn't ambulate well, and it's hard for them to get in and out of a certain machine. So you're right. Yeah, you have to be able to pivot. It's the only way you can get through the volume that we get through.
Yeah, and the last question before we move on, I want to just ask you a question about how do you educate patients the most efficient way? Because I think so much of what we do, and especially that initial visit to me, is the investment. It takes a little bit longer, right? But you take that extra time to educate them on what to expect, what is glaucoma, what I'm going to do for you, what is pressure, why is pressure important to follow up, et cetera. That gives you then the follow-ups that are much faster, more efficient, because they already had that education. They understand what to expect over the time, over the future. How do you educate them? Is there any kind of pearls you can leave our audience with that can help you more efficiently educate your patients, especially on earlier disease, early encounters? Any pearls you have on kind of quick education tools that you use, or how do you educate them? Any pearls that you found works?
Yeah, I mean, unfortunately, I think that just takes time. I mean, either you have to do it or you have to have trained staff that you trust to do it. But yeah, I don't think there's any amount of handouts or brochures or website links that get the job done. I think it just requires some chair time. But I agree that investing in that upfront, so that you're in a treatment alliance and on the same page is really important.
I agree. I think the only other pearl I have is I do a good bit of homework beforehand, whether it's on the train in the morning or the night before. For the new patients, I do try to go through their history so I can go in and I can kind of like fill in the gaps as they're sort of retelling their story. We're kind of going through it together. So I think being prepared definitely helps. The patients are more comfortable. They tend to trust you a little bit more, and maybe they don't need quite as much education because they know that you got it. I do love the OCT. I just think going through an OCT with the patient sometimes is really nice. They sort of understand what's going on. And then I agree with Sarah said about technicians. So my techs are great. It starts with them. If your technicians and your staff understand, what you're doing, it's amazing how many questions they will answer without you being in the room.
Oh, that's great. And the more educated staff you have, the more kind of, I think, foundation you have, the more they become accountable and the more they can help you as their extenders. Absolutely. There's right. Awesome stuff, guys. Listen, let's take a quick break just for a few minutes here, and then we'll get the audience a chance to get some coffee. And then we'll come back and we'll talk about some more cool discussions on flow and technologies in our clinical practice.
This podcast is sponsored by ZEISS Professional Education.
All right, everybody. Well, welcome back. Thank you. Hope you guys had a nice short break there. But we're back here with Sarah Van Tassel and Joe Panarelli out in New York, both awesome surgeons. We just had a good discussion on all the different diagnostics we do. We have a lot of different flow and efficiency pearls that, it's not easy, right? We have a lot of patients. Patients get mad waiting, and we're trying to make these decisions on progression or on surgery or on drops or drug delivery, whatever we're making. How do we make it kind of in a quick, efficient way with confidence, and then being able to follow people long term, right? Now people are living much longer, and we have a lot more data to sift through. So, Joe, you're in an academic institution. You get fellows and residents all the time coming at you with all this decision making. What do you do, man? How do you kind of follow patients? What do you use to follow patients, either from an earlier or severe glaucoma? Any difference between those two?
Yeah, it's a great question. I think I always tell patients, I tend to escalate treatment if you are progressing or likely to progress. And, it sounds so simple, but it is not that simple. But I will say I do rely on a lot of the testing modalities that we have. We have a ZEISS OCT, and I will track the RNFL over time and see how it changes. Similarly with my Humphrey visual fields, I'll track the visual fields, and I'm probably a bigger fan of trend-based analysis, and I'll look at the VFI and see what's going on. But to me, the big thing is how often I'm testing, and that has changed over time. And so I think you need to do things right. You need to get your baselines, and then you need to get your tests spaced out properly. Sometimes you can do too much testing. Sometimes you don't do enough testing. I mean, I think one of the most important things that I learned in my fellowship was the importance of repeating a visual fields because of some of the variability issues that you can have. So, I think for me personally, those are the tools I use. I know some of my trainees teach me how to use some of the new fancy tools like Forum to really track progression. And it's nice to have all the tools available, and a lot of patients enjoy that, I think, more than anything. They enjoy understanding why you're making a certain decision.
Yeah, no, that's a great point. I'm going to get back to you, Joe, on some things that you just said earlier, but you just mentioned something called Forum. ZEISS has a kind of a cool system, Glaucoma Workplace. So before I talk about it, Sarah, I know you use it. Do you want to talk about what Forum is, what Glaucoma Workplace is, and how it's helped you maybe make decisions in terms of more efficiently and more confidently?
Yeah, Glaucoma Workplace is sort of the data hub for glaucoma management for my patients. I think the nice features are that you can see pretty much all of the data on one screen at the same time. So the visual field data, the OCT data, and photos, if you wish. And it really gives you the at-a-glance view and also the autonomy to eliminate scans that have artifact, to reset a baseline if a patient has had an intervention, and to look for progression over time, to do that quickly. And I think we spend a lot of time talking about looking for progression. It also gives you confidence in looking for stability, which I think is equally important. You want to know that your stable patients are actually stable. And so it's nice to be able to see it all on one screen, all in one place, and you can use some of the tools there for patient education, as Joe was describing. You can do the sort of the little line that shows how quickly the BFI is changing.
We don't want that. We want
yeah, that is like the universal slope of doom that resonates with patients. So
I would say one more thing. Sometimes it's also nice to see, when it isn't quite that slope of doom. But yeah, listen, sometimes people are going to get worse slowly, but you can show a patient, like, here's your trajectory. I may not be able to stop this, but you're going to be okay if we continue along this path. And I think that is a challenge as the glaucoma specialist. I think we all get sent patients, and we're being asked to sometimes do the impossible. How do you stop this? And it's nice to be able to show a patient, like, listen, our job is to preserve your independence, is to keep your fields moving at a rate that's slow enough that you're going to be able to maintain functional vision. And when you can do that and show them that, I think it's powerful, because they're scared, and rightfully so.
Yeah, you guys made some great points. I mean, I think, Sarah, your point too as well about kind of equally as important to say, look, to a patient, congratulations, you actually are staying fairly stable. That line isn't going down at all, or the great glaucoma progression analysis shows us that you're not progressing significantly. So great, you're taking the drops, or that surgery we did for you is stabilizing. It's really important to reinforce that positive behavior, because we know compliance is tough. And if someone's taking medications and their pressures are doing well, and you can show them they're stable, that really means a lot to them to kind of continue that compliance as well. And I think the glaucoma workplace, which is kind of cool forum, is you can kind of go in there. It gives you a summary, then you can go into dive details. You can go into real, as you mentioned, Sarah, you can go into really detail, look at fine and granular level, or back up. And the glaucoma workplace, that one single screen that gives you the check marks, right? It kind of tells you green or yellow or red. It doesn't tell you if someone's progressing 100%, but it tells you, hey, doc, look a little more closely at that as well. So if you're in a busy practice, that's kind of help from the efficiency. And if you see those green check marks, you know that overall there's been pretty good stability overall. But I think for me, it's all about decision making, guys, right? I mean, it's really, to your point, Joe, we can't always stop the progression, but we can hopefully slow it down enough where they won't outlive their glaucoma. Hopefully, right? They'll be gone before the glaucoma causes problems. But the question is, when do we make that trigger? What are some of the things that you guys find that helps you make the trigger to do something more? Is it IOP? Is it GPA? The progression analysis on fields, on OCTs? Tell me about some of the key pearls that you can tell our viewers out there. How do you make that decision to change therapy, add therapy?
It's a great question. It's what I try to teach fellows how to do in an entire year, which I'll try to answer in the next 46 seconds. But I think for the pre-parametric patients, for those mild patients, you're really trying to look at your OCT, and you're trying to look for structural changes to the optic nerve, and you're trying to pick up what we always talk about as progression in the green. We want to pick up changes before, hopefully these patients have functional, visual field loss. So, I think you have to pay close attention, do enough OCTs, really track certain quadrants in patients, and again, do a thoughtful clinical exam. Pressure is always important, but as we all will say, that it's just one variable. It's the only modifiable risk factor. But for my moderate to severe patients, really, I am looking more at the visual fields, and typically I want to see progression, and I want to see it confirmed on a repeat field. And typically, if I see that, those are sort of my basics. in terms of how I do things. There are definitely some situations where I will, maybe wait a little longer, and some situations where I'll maybe get in a little bit faster, depending upon the family history, the age of the patient. But in general, those are sort of how I do things. The one thing I've stopped really doing is doing visual fields in some of these patients with a normal RNFL. I just don't know how helpful it is. That's always a question I like to ask people. Maybe I'm just getting crazy.
No, that's a really good point. I mean, I think you're absolutely right there. Number two, I think it also depends on how many fields you do. You're absolutely right. You do too many fields, that can cause some artifact. You can't make a decision based on one field, which is why I think the progression analysis and doing a couple baselines and then following patients over time is important. And that's what I was going to ask you guys another question is like, how many fields do you do before you make a decision? I mean, Sarah, you want to talk about that too? I mean, do you look at fields and make, if there's one change in the field, are you automatically switching? Or are you correlating that with OCT and with IOP? And that's a question a lot of surgeons ask.
Yeah, I think a wildly above goal IOP or a disc hemorrhage are the two things that would make me change management based on a single visit. Like I would change the management because of those two things. But changes on the visual field or changes on the OCT, I almost always want to see the patient back to see if it's repeatable before I would make a decision change. I think you have to be careful with those field changes because I think sometimes a patient will, throw a supranasal step and you'll say, well, I think this might be real. Let me see you back. And then they come back and their field is normal. And I would say the caution there is that might actually be sick tissue. I often refer to those as flickering defects in my notes. So it's not necessarily a reason to change therapy, but you have to be careful that you're not cavalier in disregarding them. In the same way, you have to be cavalier that you're not escalating therapy unnecessarily. So I think it's a balance, but confirmed change on OCT, that would probably make me escalate therapy. Confirmed change on a visual field or a flickering defect might make me escalate therapy.
Yeah, no, those are great comments. And I just want to leave us by saying, it's so important to understand compliance is an issue. Education is a key. So for me, I think that I always look at when I see a change and I'm trying to see, hey, look, should I add more therapy? Should I switch therapy? The question is, are the patients compliant with the current therapy? That's why I'm a big fan of getting people off of medications as much as possible, because poor compliance can be the other elephant in the room where that could be the reason why patients are getting worse. And so I think giving patients enough understanding of the disease, understanding of why we're taking the medications or why they're having follow-ups, et cetera, is such a key component to getting them to improve their compliance, to kind of follow up the way you should follow up as well. But because it's such a complex disease, and knowing how aggressive to be in every patient is so different. That's what makes it a unique art form versus a cookie cutter approach as well. But man, I could sit here and talk to you guys for like 3 more hours. I wish we could, but it looks like we're gonna have to wrap it up just for the sake of time, because I'm sure people don't want to hang out with us that long, right? But it was so much fun, guys. Thank you so much for all your comments and your pearls as well. And hopefully we'll get some more discussions coming your way soon. But thank you everybody out there for hanging out with us on GT the podcast. Hopefully this was helpful to you as well. Take care. Thanks, guys.
Thank you for tuning into this episode of GT the podcast. If you have any feedback or topic suggestions, find us on Instagram, LinkedIn, Facebook, or Twitter. And stay tuned for more hot topics in glaucoma care on GT the Podcast.